sensations a person can experience. Thankfully, we have access to one of the most powerful classes of painkillers. Opioid drugs, sometimes called narcotic drugs. It is a group of drugs that act on the central nervous system to produce morphine-like effects, such as pain relief, sedation, and euphoria. It is divided into three classes: narcotic agonists, narcotic agonist antagonists, and narcotic antagonists. Narcotic agonists include morphine, heroin, codeine, meperidine, tramadol, levorphanol, methadone, oxycodone, oxymorphone, opium, and fentanyl. But in this video, let's focus on me. Hi, I am Fentanyl, and this is my autobiography. My generic name is fentanyl citrate. My brand name is Sublimate. I am also available as fentanyl nasal spray, fentanyl sublingual spray, fentanyl transdermal system, and fentanyl transmucosal. This is my chemical name. I am therapeutically classified as a narcotic agonist. I am pharmacologically classified as an analgesic, adjunct to anesthesia, and anesthetic. I am pregnancy category C. This is my mechanism of action. When the full narcotic agonist is inside the central nervous system, such as heroin, morphine, and methadone, it binds to the opioid receptor. This results in full activation of the receptor and full opioid effects. Again, opioids will bind to opioid receptors found on pain signaling neurons, causing molecular and cellular changes that prevents these neurons from sending signals to each other, therefore stopping a person's sensation of pain. My absorption varies with form administered. Fentanyl sublingual tablets is 54% bioavailable, transmucosal lozenges is 50%, buccal tablets is 65%, sublingual spray is 76%, and nasal spray is 64%. Fentanyl distributes rapidly from plasma to highly vascular tissues such as the heart, lungs, and brain. The high lipid solubility of fentanyl contributes to a large volume of distribution. It crosses the blood-brain barrier and the placenta. Fentanyl is metabolized almost exclusively in the liver. Within 72 hours, 75% of a dose of fentanyl is excreted in the urine, and 9% is excreted in the feces. The half-life of fentanyl is 7 hours. Fentanyl sublingual spray is 5 to 12 hours. I am indicated pre-operatively and as an adjunct to general anesthetic, adjunct to anesthesia, adjunct to regional anesthesia, induction and maintenance of anesthesia, post-operative analgesic, management of chronic pain, and management of breakthrough cancer pain. I'm contraindicated in patients intolerant of drug. Use cautiously in elderly or debilitated patients, those with head injuries, those with increased cerebrospinal fluid pressure, those with chronic obstructive pulmonary disease, those with decreased respiratory reserve, those with compromised respirations, those with arrhythmias, and those with hepatic renal or cardiac disease. Side and adverse effects include sedation, somnolence, clouded sensorium, euphoria, dizziness, headache, confusion, asthenia, nervousness, hallucinations, anxiety, and depression. Hypotension, hypertension, arrhythmias, and chest pain may also develop. Nausea, vomiting, constipation, ileus, abdominal pain, dry mouth, anorexia, diarrhea, and dyspepsia may also happen. Other side effects include urinary retention, respiratory depression, hypoventilation, dyspnea, apnea, reaction at application site which may lead to erythema, papules, and edema. Pruritus and diaphoresis may also occur. Physical dependence is also a side effect. Before treatment, the nurse must assess for possible contraindications and cautions, perform a physical examination to establish baseline data before beginning therapy. Fentanyl may cause bradycardia. Pre-treatment with an anticholinergic such as an atropine or glycopyrrolate may minimize this effect. High doses can produce muscle rigidity. This effect can be reversed by naloxone. Many anesthesiologists use epidural and intrathecal fentanyl as a potent adjunct to epidural anesthesia. Transdermal fentanyl isn't recommended for post-operative pain. Observe patient for delayed onset of respiratory depression. Dosage adjustments in patients using the transdermal system should be made gradually. Reaching steady-state levels of a new dose may take up to 6 days. Delay dose adjustments until after at least 2 applications. Most patients experience good control of pain for 3 days while wearing the transdermal system, although a few may need a new application after 48 hours. Because serum fentanyl level increases for the first 24 hours after application, analgesic effect can't be evaluated for the first day. Monitor patient for at least 12 hours for adverse reaction to transdermal system. Serum fentanyl levels decrease very gradually and may take as long as 17 hours to decline by 50%. Tell patient to apply a replacement patch to a new site if another patch is needed after 72 hours. Warn patient to keep lozenges out of reach of children. And advise patient on proper disposal of lozenges.